fortunate enough for our second external speaker to have Massimo Baiocchi, who is the head of cardiothoracic and vascular ICU at the Sant'Orsola Policlinico in Bologna. And as you know, Bologna is about 70 miles away from Codogno, which is where patient 0 was traced to. In Italy, has been one of the hardest hit regions in the world. The hospital has been overwhelmed with a number of patients, and I think as Dr. Baiocchi will be able to confirm, the Sant'Orsola Policlinico was among one of the highest hit in the nation. So Massimo, thank you very much for being able to join us today. We really appreciate your perspective and the time you spent with us to give us an outlook on what has happened in Italy and the measures that have been taken to deal with this crisis.
Good afternoon, everyone. Can you hear me?
Yes, we can hear you.
Okay.
Yes.
Okay. Thank you. Good afternoon. I thank the committee for having invited me at this meeting. I am a cardiac anesthetist and intensivist, and I'm chief of the cardiothoracic intensive care in Bologna University Hospital. I will talk about the intensive care organization and critical patient treatment protocol in COVID-19 era. This is Bologna City, almost 400,000 inhabitants. It's a city full of culture and has been officially recognized as the European Culture Capital in 2000. But the SARS-CoV-2 virus appeared in Italy for the first time on 20 February in Codogno town in Lombardia region, North Italy, where a 30-year-old man has been admitted in intensive care for severe respiratory failure. Bologna City is located in Emilia-Romagna region at the southern borders of Lombardia region. The viral spreading has been less than Lombardia and mostly affecting the small city of Piacenza, which is very close to Codogno town. We have admitted the first COVID-19 patient on the 1st of March, coming from Piacenza. Since then, a rate of 3-4 patients per day have been admitted in our ICU, most of them coming from Lombardia region borders. We have filled up the intensive care unit in 1 week with a total number of 18 patients. At the end of the second week, we realized that this was not enough, so 25 additional ICU beds, usually destined to postoperative abdominal general surgery in another pavilion of the hospital, were promptly converted to COVID-19 beds. This has caused an interruption of surgical activity there, only urgent cancer surgery being on hold. At the end of the third week, we realized that this was still not enough, and we thought and obtained to restore the old cardiac surgery pavilion with 16 more ICU beds, reaching a total number of 60 intensive care beds completely dedicated to COVID-19 patients. At the same time as our hospital, the other 2 hospitals in the city have also been converted to COVID patients, making available 46 more ICU beds, reaching a total number of 106 intensive care beds in the city. It was also necessary to create a control center with the purpose to manage in real time patient allocation into the different intensive care units of the city. And this is my hospital. This is the oldest and most important university hospital in Italy. It involves more than 4,000 workers and can count more than 30,000 surgical operations per year. This center is a cardiothoracic and vascular department of Sant'Orsola, which has been fully activated in December 2015. There is a multidisciplinary team of anesthesiologists, intensivists, cardiologists, cardiac, thoracic, and vascular surgeons. The building is made up basing on intensity of care criteria. The lowest intensity of care, the ward, is based on the first floor. The high dependency care with monitored beds is based on the second floor, and the highest intensity of care intensive care unit is based on the third floor. At the fourth floor, we found 6 theaters, 2 cath labs, and 2 hybrid operating rooms. At the third floor, we potentially have 42 high-intensity beds located in 2 parallel wings in negative pressure boxes. Each box is provided by 6 ICU beds. Additionally, we have 3 isolated negative pressure boxes. In our cardiothoracic department, we have isolated an entire intensive care wing with a total number of 18 beds plus 3 isolated boxes to receive patients. But we reserve additional 18 beds for cardiac surgical critical patients, emergency cardiothoracic surgical activity, and patients with ventricular assist devices department. We have converted positive pressure boxes into negative pressure boxes, and we have created a clean bubble zone. This is the bubble zone inside the box to visually inspect the patients and parameters without entering into the decontaminated area all the time. The bubble zone was built in 2 hours with a metal frame and a plastic coating in every box of 6 beds. The personal protection equipment is mandatory and pretty much important for the safety of health care workers who need to come into contact with patients. We use waterproof suits with boots and ventilated helmets for any procedure involving patients' airways, like intubation, fiber optic bronchoscopy, percutaneous tracheostomy, and in other procedures such as positioning or with the ECMO. The ICU admission peak in Italy was on the first 5 days of April, reaching a total of 4,000 ICU admissions, over a total national availability of 5,000 ICU beds. In the last week, we are facing a progressive reduction in ICU admission, coming from early home treatment protocol with hydroxychloroquine and azithromycin, but above all, from the social isolation and quarantine measure imposed on the entire population from Monday, 9 March. This is the current Italian situation with almost 160,000 total cases, more than 20,000 deaths. Currently in hospital, patients account for a total number of 28,000 placed in the ward and 3,200 patients admitted to the intensive care. But what about treatment protocol in our hospital? We are in the total absence of randomized controlled trial, and there is no strong scientific evidence. But the task of medicine is to offer the best treatment considered at the time. So, the clinical course of this disease develops in 3 phases. An initial phase characterized by a strong viral replication with symptoms such as fever, cough, and anosmia. And a second phase with high fever, hypoxia, pneumonia, with a decline in viral replication. 10% of patients progress in pneumonia and acute respiratory distress syndrome. The third phase is thought to be the result of an exuberant host inflammatory response, and the immune dysregulation seems to lead to a progressive cascade of events that makes the disease critical with multiple organ dysfunction. In the current state of the recommendation, antiviral therapy is not recommended in ICU patients. In this patient, it's assumed that stage 1 of high viral replication is already passed. A 3-day cycle azide or vancomycin and hydroxychloroquine is recommended with the aim of reducing intracellular viral replication and modulating inflammatory host activity and response. With the same purpose, we use corticosteroid for 5 days at low dose. We use tocilizumab. Tocilizumab is an inhibitor of interleukin-6 production as an immunomodulatory purpose to be used early in patients with severe pneumonia and high levels of interleukin-6. Enoxaparin at therapeutic doses of 100 units per kilo with immunomodulating and anti-inflammatory activity and to counteract evidence of coagulant status linked to inflammatory that causes the detection of thrombosis and the pulmonary circulation and the multi-organ dysfunction. And then, in patients with severe respiratory insufficiency, as protected as possible is performed. Now it's a pleasure to introduce to you Dr. Benedetto. She will talk about the mechanical ventilation strategies and feasibility of.
We'll talk about the mechanical ventilation strategies. For RDS, the mechanical ventilation strategies should be tailored for each individual patient according to its lung mechanical properties, should be titrated to achieve safe plateau pressures below 30-32 centimeters of water, and should aim to achieve normal values of pH and acceptable gas exchange. However, we cannot consider COVID-19 associated pneumonia as a classic form of RDS, especially at the disease onset. And two key concepts we have to consider at lung disease onset: compliance and hypoxia. Compliance because more than 50% of these patients have normal or nearly normal lung compliance, and hypoxia because the majority of patients is severely hypoxic. So the evolution of pneumonia observed so far allows clinicians to identify two types of COVID-19 associated pneumonia: type A or low inflammatory phenotype, and type B or high inflammatory phenotype. And only type B may be classified as a classic form of RDS. In this disease, we all know that CT scan plays a big diagnostic role. Through the chest CT scan, we can monitor the clinical evolution of the disease, and it should always be performed at the hospital admission and at least after 1 week from the admission. Which will be the chest CT scan found at the disease onset. So first of all, we have to say that chest CT scan is even more sensitive than PCR in detecting the early stages of the disease. It has a sensitivity of 56 to 98% and may identify false negatives, and it shows at the early stages areas of consolidation, ground glass opacities, interstitial thickening, bilateral peripheral parapleural involvement. But when the crossover from type A to type B takes place, well, in a spontaneous breathing patient, when tidal volume increases, negative pleural pressures increases as well, and this leads to an increase in pulmonary blood flow. This can cause pulmonary edema, the initial phase of RDS, and when pulmonary edema overcomes pulmonary gas level, we fulfill the criteria for the definition of severe RDS. And where we can deal with the type B? Well, when the patient is severe hypoxic, severe dyspnea, and has chest pain, probably the urgent call for intensivist is needed. And what will be the chest findings at this stage? So we can find ground glass opacities in non-dependent lung regions in 86% of cases, bilateral peripheral involvement in multiple lobes in 82% of cases, progression to crazy pedi patterns and consolidation in 64% of cases, and vascular enlargement in the lesion in 71% of cases. Ground glass opacities indicate partial filling of air spaces in the lungs by exudates on transudate. Through the chest CT scan, we can monitor the evolution from type A or low inflammatory phenotype to type B or high inflammatory phenotype. But how to avoid, in terms of intensive care work, how to avoid the crossover from type A to type B? So we should find the best solution between non-invasive and invasive mechanical ventilation. And how to find this solution? We should ask ourselves a few questions. Is patient generating excessive pleural negative pressures? And how to measure pleural pressure swings? So the gold standard to measure negative pleural pressures in a spontaneous breathing patient is the esophageal balloon, which is rarely used in a pandemic scenario. So there are some surrogates of excessive negative pleural pressure, clinical signs of severe dyspnea, excessive systemic arterial curve oscillations, and paradoxical movement of respiratory muscles. In these cases, so if patient presents one or more of the following: severe dyspnea, excessive systemic arterial curve oscillations, and paradoxical movement of respiratory muscles, or is not receiving any benefits from non-invasive ventilation up to 24 hours, then let's go for intubation, because timing is the key factor, and in 48 hours, lung function may dramatically fail. So we should put the lung at rest as soon as possible, because early intubation allows us to stop tirage and to reverse the increase of negative pleural pressure. In 48 hours, patient can develop severe ARDS and be potentially affected by bacterial superinfection. And what about the nitric oxide? Well, when the lungs are not yet vasoplegic, they respond with epoxy vasoconstriction. In such patients, it's reasonable to use inhaled nitric oxide with two purposes: in order to decrease ventilation perfusion mismatch, in order to decrease the risk of microthrombosis and higher coagulability due to epoxic vasoconstriction. And we have seen it in several patients. Several patients developed pulmonary embolism due to severe pulmonary vasoconstriction. So in conclusion, how to mechanically ventilate COVID-19 associated pneumonia? Set the best PEP at the lowest driving pressure. Consider prone position, especially in the high inflammatory phenotype, and blood flow distribution. And once the patient is intubated, well, keep the patient intubated for an average amount of time of 6 days, during which the level of muscle blockade can be progressively reduced. And now we know, as we said earlier, we are an ECMO center. We have the reference center for BV ECMO placement in cases of H1N1 pneumonia and in case of COVID-19 associated RDS. So this is the protocol coming from EuroELSO. So there are two main indications in the use of BV ECMO: APF ratio under 150 millimeters of mercury. Once you have already tried prone positioning cycles, neuromuscular blockade, high PEP strategies, inhaled pulmonary vasodilators, and all recruitment maneuvers. But the patient has still PF ratio under 80 for at least 6 hours, or under 50 for at least 3 hours. But on the other side, we can also consider the use of BV ECMO in cases where the PF ratio is over 150, but the pH is minor than 7.25, with PCO2 over 60 millimeters of mercury for more than 6 hours. What is the main advantage in using BV ECMO? Through the BV ECMO, we can put the lung at rest. So, because the most challenging issue while dealing with this patient is to find the best solution of ventilation. So with the ECMO, we can do a near apneic ventilation, which means low mechanical power. Low mechanical power is a component of main variable that are tidal volume, respiratory rate, positive end expiratory pressure, and these all may cause VILI, so ventilation-induced lung injury. In this sense, ECMO offers a tool allowing to protect the lungs by reducing the mechanical power delivered to the injured lungs.
Just giving you a 1 minute warning.
Sorry?
1 minute warning.
Okay.
Thanks.
Hello? Can I go?
Yeah, you can go. I said we have 1 more minute. I just wanted to give you.
Okay. So this is the important study in ear, neck ventilation, which promotes a PEEP not over 10 centimeters of water, driving pressure not over 10 centimeters of water, and 5 breaths per minute. And the reduction in terms of mechanical power and so injured lungs is pretty much less. There are ongoing studies that will consider whether lung arrest is superior to conventional treatment in promoting healing, increasing ventilation-free days, and survival. And this is only a resume of our experience so far. We have admitted a total number around 60 patients. 5 patients were negative for SARS-CoV-2 testing, were positive for rhinovirus and H1N1. So far, we have 15 deaths. 30 patients were weaned from mechanical ventilation. 23 patients received tracheostomy. The mean age was 59 years, and the mean BMI was grade 1 obesity. We have 4 BV ECMO, and 1 of them is still running. 2 were weaned, and 1 dead for hemorrhagic shock. Thank you very much.
Thank you very much, both Massimo and your collaborator. I'm not sure I caught her name, but this was very informative.
Maria.
And Maria?
Maria.
Okay, thank you very much for the very informative presentation. And we have a couple of questions here. Steve Ho.
All right, thank you so much. Massimo, can you confirm that, so 2 questions. So number 1 is that, can you confirm that hydroxychloroquine and azithromycin is ineffective based on your experience, contrary to what we read in the media? And number 2 is that, what kind of a protective care do you recommend? Do you recommend like a positive pressure suit so that the suit has a mechanical ventilator rather than a, let's say, just wearing an N95 face mask? Thank you.
Okay. I can confirm the efficacy of hydroxychloroquine, but we haven't yet a CT. We need more studies to definitely confirm the efficacy. And for a second question, the positive pressure is only on the helmet, not in the suits, only in the helmet.
Thank you.
Thank you, Massimo. Margaret?
Hello, thank you so much for your talk. I have a little bit of a different question. And I'm just curious because the region of Italy that's been hit hardest by the COVID-19, where you all are, in fact, is also an area where there has been significant a significant number of migrants and immigrants. And I'm wondering from a medical standpoint, how have they been impacted by COVID, or do you know?
Medical staff. So are you asking us if medical staff there has been affected by COVID-19?
I'm asking.
Maria, Margaret, let me translate.
Okay.
Margaret sta domandando se c'è stata una disparità nel trattamento delle persone che sono immigrate, per esempio dalla Cina o da altri paesi.
Okay. No, there was no difference in the treatment at all. So we just started realizing that the early treatment in all, even in all population, even with low symptoms, was needed, because when patients come to the ICU, they're already too severe. So mechanical ventilation is just a way to support their life. But what made a real change was to understand that we had to stop the inflammatory process at an early stage. And it was done in all population, not considering difference in any case.
Thank you. Janine Darmiento?
Yes, hi, Maria, thank you both. This is a wonderful presentation and sharing with us. What I was wondering about is that we're all disturbed by this vascular component of the illness. and the sudden decline, sudden hypoxia. Did you get some benefit from the use of the nitric oxide, obvious, that you saw early on?
Yes, okay. We can say for sure that most part of these patients have a higher state of coagulability, and they are severely hypoxic. So in patients with a persistent severe hypoxia, when we made the follow-up CT scan, in most part of them, we found a high level of peripheral pulmonary embolism. So we started use ethylene nitric oxide in all patients with a severe decrease in PO2 with a PF ratio under 100, not only with the purpose to provide a more adequate oxygen level, but also and because we found in most cases peripheral pulmonary embolism due to hypoxic vasoconstriction, because when the, as I said before, when the lungs are not yet vasoplegic, they respond with severe pulmonary vasoconstriction. So it is very important to provide adequate enoxaparin dosage, and if you have the availability to use inhaled nitric oxide. Obviously, if you have nitric oxide and use it, you don't have to go with a very high FiO2, otherwise you match the side effects of inhaled nitric oxide with nitric peroxynitrate and stuff, and with oxygen radicals. So if you use nitric oxide, you go the lowest possible with FiO2 at the ventilator. But for sure, it's a very important tool in these patients.
Thank you.
Thank you, Maria. So I have a last one, Maria. Is it okay for us to record and distribute your presentation both within Colombia and externally?
Yeah, no problem.
Wonderful. The second one, there's been a lot of misinformation with some members of the medical community suggesting that the actual rate of death by pneumonia has really not dramatically increased compared to other years. And I found that to be extremely upsetting and misleading. And I was wondering whether you had any kind of sort of reaction from the medical community with respect to those, but also if you had specific data on how much the actual death by pneumonia rates have changed with COVID-19.
Okay, we can. Okay, we share our experience between centers in the northern Italy, and Massimo was talking with some director of other ITUs, and actually we found out that our mortality was a bit less. In Lombardia region, they had a mortality that was even worse than 50%, even worse than 50%. And this was because the contemporaneity of cases lead anesthesiologists and intensivists to just choose how could live and who could live and who could not live. And one enemy of this pneumonia is the non-invasive ventilation. But when you have not enough ICU beds, you go for it. So and this had dramatically impaired the outcome of these patients. Bologna has a national system which is almost ideal because it's a pretty small town with very important hospital, a very good organization. And in our department, Massimo is the leader, and we are very independent, even in performing procedures, tracheostomy, ECMO. So we are very fast in treating patients. We don't need the surgeon to be called for tracheostomy, the vascular surgeon to be called for the ECMO. So all our staff is independent in provide all the care to patients. So probably this can explain why we have a lower death rate. Plus, I think, and Massimo, I'm sure agrees with me, they were our trial. I mean, Lombardia region doctors have made the first trials, and probably they have been sacrificed also.
So I'm going to translate the Italian part of my question because I think it was missed. Stavo chiedendo, perché ci sono stati alcuni reports che il numero di morti da polmonite non sono aumentati con il Covid-19. Questo mi è sembrato molto misleading, quindi stavo chiedendo se ci sono delle statistiche ora che fanno vedere chiaramente che c'è un incremento drammatico delle morti da polmonite.
Per rispondere in italiano perché non saprei come dirtelo in inglese, però sì, sono completamente sbagliate. Ho visto anch'io dei dati dell'Istat
Okay, I will translate your
cercano di
response.
comparare. Ok, grazie. Che cercano di comparare i due dati, ma secondo me c'è proprio un errore alla base, anche perché probabilmente si sta parlando di pazienti che non arrivano in terapia intensiva, sono pazienti estremamente anziani con tantissime comorbidità. Al contrario, nel Covid i pazienti hanno un'età media attorno ai 60 anni e anche meno a volte. Noi abbiamo avuto pazienti ricoverati, il più giovane aveva 38 anni e con gravissime polmoniti e con un livello di mortalità molto molto elevato. Noi siamo attorno al 30-35%, altre terapie intensive sono attorno al 50, anche 60% nelle zone di picco. La Lombardia purtroppo non era preparata, è arrivata purtroppo per prima, è stata una zona di picco di contagio e quindi la letalità è diventata sicuramente più elevata. Però questo è un dato, sono dati incomparabili, non esiste proprio, cioè terapia intensiva noi non abbiamo avuto tanti pazienti ricoverati per polmoniti contemporaneamente mai da 20 anni a questa parte.
Grazie. So let me translate for you. So the question was that there have been reports that the overall death rate by pneumonia in Italy had not really changed, and that appeared to be very misleading. The answer was, in fact, that not only the number of deaths and the rate of death from acute pneumonia has dramatically increased, but also that the age groups in which these phenomena have been detected has also changed quite dramatically. Under normal situations, the population that presented in the ICU was actually generally above 75 to 80 years old, while with COVID-19, they've seen a dramatic increase in the number of acute pneumonias reported for a younger population, so even from the 30s to the 60s, with an average admission to the ICU age of 60 years old. So this is just unprecedented and really not and completely contrary with some of these to the report that have been circulated. Thank you very much, Massimo. I don't see any additional questions, but this has been extremely informative, and we owe you a debt of gratitude for taking the time from Italy to connect.